It's both an honor and a privilege to introduce you to today's keynote speaker. Senator Stephen Meredith's career is marked by achievements and a passion for driving positive change. He knows the challenges facing our healthcare delivery system because he's seen them firsthand. By the age of 29, Senator Meredith was named the Chief Executive Officer of what is now called Twin Lakes Regional Medical Center in Litchfield, Kentucky. Under his leadership, the hospital transformed into a thriving institution. Currently, Senator Meredith serves as the chair of our Kentucky Senate's Health Services Committee, demonstrating his enduring commitment to advancing healthcare policy. His wealth of experience and dedication to public service promises to enlighten and inspire us all. So, without further ado, please join me in extending a warm welcome to Senator Meredith.
Good morning. Such a pleasure to be here. Let's take a moment. Just stand up. I know you've been here a long time. Just stand up and stretch just a little bit and let you get comfortable. All right, sit down. We got stuff to do. Truly do appreciate the opportunity to be here and that very gracious introduction. I'm not sure how well deserved it is. It kind of reminds me of something I said to my wife once. I'm 5 years older than she is, and she reminds me of that constantly. And when she turned 60, I thought, here's a chance to maybe get a little jab in on her. And I told her very disrespectfully and very crassly, I said, I'd never made love to anybody this old before. And she quickly said, I have, and it's no big deal. That's kind of feel about the introduction is I'm just a simple country boy who wanted to get back to my home community and was blessed to be able to do that. And I'm not sure what a keynote speaker is supposed to do. I'm not here to teach. I'm not here to preach. I hope I am going to be able to give you kind of a challenge for the future, because we have challenges. We have a multitude of challenges, you folks well know. But you notice the title of this talk is actually an oxymoron. If you're an English major, you know that. Any English majors? I'm proud that you admit it. I've never met one before. But it is an oxymoron. Contradiction in terms. How do you fix an irretrievably broken healthcare delivery system? You can't. So what time does Keeneland run today? Do they run today? Maybe we can leave early and do that. Some folks say you're being much too critical of the healthcare delivery system. In spite of all the woes that we hear today, it is a fantastic healthcare system. And you look at the advances, at least I've seen over my 7 years of life, it's phenomenal. One that most starkly comes to mind is childhood leukemia. How when I was a child, that was a death sentence. And now there's like a 97% survival rate. The advances in technology have just been phenomenal, such as laparoscopic surgery. Back in the old days when you had your gallbladder removed, you were out for 6-7 weeks and had a scar that's about 2 foot long. And today it's changed where you can literally go back to work almost the next day. Matter of fact, my small rural hospital was one of the first in Kentucky to do laparoscopic surgery. And the first person who had it was a well-known person in my community, and I was quite concerned about the outcome. And so I called him a couple of weeks after he had his surgery. I said, Otis, how's it going? He said, not too well. I said, uh-oh, what's the problem? He said, well, I went out and played tennis, so I probably shouldn't have done that. But again, life's changed so much. But I don't think I'm being too critical. And some of our speakers already attested to the issues that we're facing here. Cost of health care is just astronomical. The average person can no longer afford it. I don't know what working families are going to do in the future as this continues to escalate. References made to poor healthcare outcomes. They're terrible. And you look at our country, really, I think we have two healthcare delivery systems, and it's unfortunate, but for those who are privileged and those that are not. And the outcomes are remarkably different, tragically different. We have and I think the greatest indictment of our healthcare delivery system is the mass of healthcare professionals who are leaving the system. That's got to be alarming. That should tell us something there's systemically wrong with the healthcare delivery system. And I'm reminded when I give talks like this of the scripture in Galatians 4:16. I tell you the truth, therefore I am your enemy. I know there's some folks here who are going to be upset by what I'm saying, and I'm not your enemy. I'm just trying to tell you the stark truth. You know, what I'm going to share with you today is based on 70 years of life and 40 years as a working healthcare professional. But I think one of the most damning indictments of our current healthcare delivery system is one of the largest insurance companies in the United States this last year. Their profit was $86.4 billion. Not million, billion. And we're spending $4.2 trillion on health care in the United States. As the slide was shown earlier, we're spending almost $13,000 per capita on health care. Next nation is Germany. $13,000 per capita. We should be alarmed by that. Not just because of what's happening in the healthcare system, but what it's going to do to us internationally. We don't live in a vacuum anymore. We have to compete on a national level, an international level. And we can't do it when we're spending that much on healthcare. Right now we're approaching close to 20% of our gross national product on healthcare. By contrast, China, our largest economic competitor, spends less than 5%. They spend roughly $600 per capita. So how are we going to create jobs? How are we going to maintain jobs in the United States if we don't get control of this situation? And we have to. Because I'm going to assure you, this is not just a concern of healthcare, it's a national threat. If our healthcare costs exceed over 20% of our gross national product, it will collapse our economy. And we say, well, that may be an exaggeration. Well, I'll remind you of the Soviet Union. Very similar situation in that they got in an arms race in the United States. We're spending over 20%, close to 25% of their gross national product on their military. And it collapsed their economy. It can happen to us as well. Then what happens to us? I think the obvious probably solution is going to be a nationalized healthcare system. Now, I know there's some folks who are great proponents of that, universal health care, but do you really want the federal government to have control over 20% of our economy? It's not just 20%, it's just not health care. Anything that touches health care will be subjected to it as well. That capitalist system that we have talked about will collapse. It cannot sustain itself. And that's one of the problems with having a nationalized healthcare system is government is not great on innovation. This country is built, if I build a better mousetrap, I'm going to be rewarded for that. But if you have control of all the mousetraps, there's not really incentive to build a better mousetrap. So this is the wake-up call, folks. This is a crisis situation that is here. And it's shown itself in a lot of different symptoms, like the shortage of healthcare professionals that we have. Now, we had a lot of discussion about data, and data is important, but the problem is we know what the issues are. We don't act on the issues. So what do we do? What should we do? Well, I'll give you a quote that's attributed, I think, kind of ironically to Peter Drucker, the management guru, but also Abraham Lincoln. And they said, best way to predict the future is to create it. So let's do that. Let's create a new healthcare delivery system. And what should it look like? What would you want it to look like? I would think probably that it would be healthcare provider driven. Would make sense, wouldn't it? Because who has more of a vested interest in this than anyone? It's healthcare providers. So why don't we do that? Well, I ask you, why does managed care exist? And most folks who follow me in committee meetings know I am not an advocate of the managed care model. I don't like our MCOs. I don't think they're doing the job that we've engaged them to do. Because, recall again, we've been under managed care for Medicaid program since 2012. It's been 10 years. We have not improved the health of our population. So why do they exist? Well, we've heard some presentations talking about some great service that they provide, and I have seen a subtle shift in the way they handle our Medicaid population with a little bit more focus on addressing the social determinants of health. But the reason they exist, particularly in Kentucky, is to assume the risk, the financial risk. The primary reason that Kentucky decided to have managed care for the Medicaid population is because the state at that time had a $750 million shortfall in funding. So they said, we're going to do a Pontius Pilate here, literally give it to the managed care organizations. Unfortunately, the next year we had a $1.5 billion shortfall. So we've been here 10 years. I was elected in 2017. The first year I was there, our Medicaid budget was $10 billion, and we were serving right at 1.3 million Kentuckians. It's as large as it ever should be. Not because I'm kicking anybody off Medicare. I think the Medicaid expansion was certainly warranted, is needed. But if we're truly improving the health of the population and we're getting people back to gainful employment, we should have enough money to take care of everyone. In inventing a new healthcare delivery system in the future, we all have to agree and acknowledge there's enough money already in the healthcare delivery system to take care of every man, woman, child in this country if we spend it the right way. But I ask you providers here, who thinks you're paid fairly? How many of you are content with the payment that you're receiving for services now? I don't see a show of hands because I'm sure most people are embarrassed to do that, but everyone I talk to says, no, we can't. We don't get paid fairly. Well, why not? Because we don't control the healthcare delivery system. Again, we have to reinvent it. And where does that start with? It starts with the mission of healthcare. And what is it? As a hospital CEO, and particularly in the 80s and 90s, it was really a kind of in vogue thing that you engage a consultant to come in and talk to people to decide what your mission and vision were. And I don't know how many $1 million we spent just on that, but I thought, this is kind of silly. If we're all united in this, it's quite simple. We're here to cure the sick, to help relieve pain and suffering, to give comfort to the dying, and to improve the quality of life of people we serve. If we're all united in that, doesn't that move us in one direction? And one thing I haven't mentioned is it doesn't say anywhere in there that to make a profit. Now, I'm a capitalist to the nth degree, and I believe in making a profit. But it's when you bring value to the system, you increase efficiencies, and you do it a better way. And we're not doing that. So we get this new mission, and the vision flows from that. And certainly you saw one earlier. We want to make sure we have affordable health care for every American, quality health care. To me, that's the vision. So how do we do that? Again, reinventing the system. I think the best way is to make sure we do it at the local level. Now, I know we have tried for years to be smoke-free Kentucky. Why have we failed in that venture? Because it comes from Frankfurt, it comes from Washington. Folks back home don't care about that at all. They don't want to be preached to. They don't be mandated to. So where's the incentive to become a smoke-free Kentucky? They just want that hassle. What I would like to see in reinventing the healthcare delivery system is take our Medicaid program and do a block grant that pushes the money back to the local level. And I'll give you a personal example. My home county, Grayson County, Medicaid budget is about $55 million. A lot of money for a small community, 26,000 population. And what I envision is a local board, probably like an ASO, Administrative Service Organization, a local board that's made up of our health department, the hospital, the mayors, the county judge executive, all the major players in the community now become this board for the ASO, charged with the challenge of improving the health of our population. And actually, the health of our population in Grayson County is poor. It pretty much resembles everybody else in Kentucky. Now, they have this $55 million at their disposal. We tell you use it, go improve the health of your population. Now, here's where you can get the catcher, and the statement was made earlier, it's all about the money. It is. And that's what gets people's attention. But we tell these locals, ASOs, if you improve the health of the population, whatever savings you achieve, you get to keep to improve your community. If you want to invest in your school system, you want to invest in an infrastructure, you want to invest in broadband internet for you, it's yours to keep. Now, a small community like ours, I think there's potentially a 10% to 20% savings by improving the health of our population. That's $5 to $10 million that's now available to Grace County they haven't had before. I can tell you, to a community that size, that's a massive amount of money. They're going to think they won the lottery 10 times over. So why don't we do that? Because people don't like risk. We like the status quo. Do a small exercise for me. I'm sure you may have done this before, but if you would, just fold your arms. Now do it the other way. Kind of weird, isn't it? Kind of uncomfortable. And if that makes us uncomfortable, just think of what a systemic change like this does to folks. But fear keeps us from doing what we need to do, but we have to. Mr. Chandler's very gracious introduction to me earlier, but I did become hospital CEO at 29. And at the same time that the Medicare prospective payment system started, in my first year I had a $500,000 loss for a hospital my size. That could have been a gazillion. I don't know what a gazillion is, but it was huge. And I knew that we had to grow our revenue quicker than the reimbursement cuts that would continue to come. Because most of the policies we've seen from Medicare over the years have not been to improve the quality of care. It's been to control cost. So I knew it was coming. At that time, I had 7 doctors on my medical staff, and I knew I had to have more physicians. So I'd go to my docs and say, guys, here's where we are. We have to grow our revenue. We need more docs. And they go, we got this covered. We're okay. Then after we got in the hallway, and this is 7 doctors, had 1 pediatrician, 1 general surgeon, the rest were primary care physicians, and they get out in the hallway and say, oh, except we need another general surgeon. So I get my general surgeon and say, hey, how you feel about getting another general surgeon here? I'll starve to death. I can't do it. So, well, what if we can change that dynamic for you? Well, most certainly. I don't want to be on call 24 hours a day. Well, we'll see what we can do about that. I'll talk about that later. But this change, as a result of it, we had a very successful run. The last 20 years, as a CEO of the hospital, our return on investment was about 6.5%. At that time, most rural hospitals were less than 2%. We grew from a 14,000 square foot facility over 300,000, from 7 physicians to over 34. I was offering full-time specialties in ENT, orthopedics, OBGYN, pulmonary medicine, had 4 general surgeons, 5 pediatricians. This medical staff grew substantially. You think, wow, that's a pretty good record. Well, I'll tell you, 4 years into this journey as hospital CEO, and again, I was hired at 29, and at that time I thought our board had to be the smartest guys in the history of the world. About 4 years into it myself, I thought, what were they thinking? They must have had the same thought, because I got a 17-page letter from the chairman of my board of directors who said, outlined what a terrible job I was doing. I remember most of the damning statement was at the very end, where he said, we are not interested in the grandiose expansion plans our hospital CEO has for our hospital. We're quite content being a small, conservative, rural hospital. Because they didn't want change and it took risk. You know, when I started a hospital, it was Grayson County Hospital. We built a replacement facility went from 14,000 square feet to 56,000 square feet and became Grayson County Hospital. And about 5 years later, we became Twin Lakes Regional Medical Center. And I tell you, it was a marketing gimmick more than anything. If you know our county, we've got Nolan Lake on one side, Rough River on the other side. So that's the name Twin Lakes. And I use an example. I said, you know, if you're on one of those lakes and you get hurt, you have a choice between, at that time, Breckinridge County Hospital and Grayson County Hospital. Which one are you going to choose? Probably a flip of a coin, really. But now you've got a choice between Breckinridge County Hospital and Twin Lakes Regional Medical Center. Which one are you going to choose? So it was a marketing gimmick, started out. But I told our board it's a name to live up to and to grow into, which we did. but not without having to challenge my own board of directors and saying, here's the vision for the future. And when I received that letter, I asked at that very moment, I said, I need a vote of confidence here that you know what I'm trying to accomplish. And fortunately, the vote was 5-4, and we moved forward. But we built, from the base up. And that's what we have to do with this new healthcare delivery system I'm talking about. We've got to get back to basics. All these things we talk about, we overlook the fact that in Kentucky specifically, primary care does not exist. 40% of our population is in rural Kentucky. Only 17% of our primary care physicians are there. And looking at your agenda for later on the day, some great questions there, and I'm going, I can answer all those for you, and I'm going to do that right now. We have to change it. I've asked repeatedly in committee meetings of the MCOs and the Secretary Freelander, why would anyone choose to go to a rural community when you know you can make 25 to 30% less than your urban counterparts? Why would you do that? And to their credit, they go, we don't know. Exactly. Well, they just said, some people just have a passion for rural communities and that's their mission. They do, but they shouldn't be penalized for that. And you folks who are providers in rural communities know it's the most challenging population in the world. Usually the most non-compliant patients and patients that are some of the sickest. Why would we not pay those people more? Well, greed. And greed's pervasive, throughout our society, unfortunately. And sometimes I think we need to, instead of doing our usual pledge of allegiance, we need to do the one that really exists in this country as I pledge allegiance to the dollar and to the greed for which it stands. One purpose only, increased profits and dividends for all. We got to get away from that. We do. Or we'll destroy this country. But again, getting back to the basics. How are we going to do that? Some of the answers are quite obvious. I filed Senate Joint Resolution 54 last session, and it just simply says that directs the Medicaid Department to develop a payment methodology based on the National Deprivation Index. That's a starting point. If you're not familiar with that index, it's based on 6 social and economic values. The federal government does it for every zip code in the United States. And this just isn't rural. We talked about the urban healthcare districts. What's the problems there as well? The pay, the reimbursement, the lack of resources. Well, shouldn't we redirect those resources to our most disadvantaged communities? I think we should, but we don't. So they're supposed to bring us a report in next month, as a matter of fact, as to what they're going to do with this. But I think it's the start of maybe a new thinking for Kentucky and maybe America. Rural America's been overlooked for too long. I remind people of Walmart. How did they make their fortune? It wasn't in the urban areas. They saw the need in rural America, and they took full advantage of it. And that's the same thinking that we have to have with healthcare, I believe. So getting back to basics, if we recruit physicians, pay them fairly, they will come to rural Kentucky. Now, I've had members of my own leadership say, well, you can't recruit physicians to rural Kentucky. I said, you're wrong. I went from 7 to 34. I can tell you, people want to practice in rural communities because they want the quality of life that we have. And what I always tell the guys that I would recruit is, you can go in the world and make a living. You'll make your living here too, but the difference is you'll make a difference in people's lives that you'll see every day. That's exactly what they wanted. But they don't want to do it if they have to discount themselves to come there. So what I offered that general surgeon I mentioned to earlier when he said, I'll starve to death, I said, if I can address that, will you accept somebody? Most certainly. I remind you again, we went from 1 general surgeon to 4. I hired him. We were one of the first small rural hospitals to have a medical foundation for the sole purpose of hiring medical professionals. And I tell the docs that if you will come here, I'll pay you the median for your specialty. And if you're really a workaholic, you'll get an incentive bonus based on how hard you work. Again, from 7 doctors to 34, because we eliminated the most obvious problem, that's financial insecurity. The first question I would always get from a prospective physician is, what percentage of your patient population is Medicaid? And now we can say, don't worry about that. What we want you to do is offer quality care regardless of what the payer is. And I think that we did that. Hand in hand with this, we had to build accountability into the healthcare delivery system. It's not there. Value-based payment, maybe that's a start at it, but again, it goes back to the local level. And I think we have to really commit that every dollar we spend in healthcare, there has to be a measurable return on investment. Doctor, you mentioned quality. What is it? I think it's getting that desired outcome. It is that return on investment. And folks say, well, this is healthcare, we're different. No, you're not. You're not any different. But I'm as serious about this as I can be. Every dollar we spend, there should be a measurable return on investment based on what you want to accomplish. And we don't ask that question enough. I remember one of the discussions we had at one of our budget meetings was with social workers. And, our state has been tragically short of social workers for some time. And they said, we need 200 more. Well, what's it going to cost? $20 million. But they'd also said, if we can have these 200 more social workers, we'll save $20 million a year. I said, great, exactly what I'm looking for. I'm all in. Now, where's that savings come from? And they looked at me and kind of eyes rolled over, and I had to ask again, where's the savings going to come from? They still kind of looked at me like it was foreign language. I asked them a third time, where's it going to come from? Finally, they answered, well, we're kind of going to absorb it in the system. That's not a return on investment, and that's part of the problem with healthcare. In any business, we have a tendency to do the same thing over and over and over again without really deciding if it has value to us. I think it's interesting we have a strange similarity between our healthcare delivery system and education in Kentucky. We're struggling there as well. I'm co-chairman of the Government Contract Review Committee, and supposedly we see every contract that comes to the state. And one that we had last year dealt with a $1 million contract we've been doing every year for 20 years to a group that was supposed to improve the reading scores in Kentucky. Automatic, $1 million a year. You folks need to know. We've been doing this for 20 years. Since 2013, our reading scores have fallen. So why do we keep spending this $1 million a year? Well, we don't know. What's part of the problem? There's no accountability, and it starts with return on investment. Every dollar you spend. I'm not a big proponent for healthcare providers in advertising, and I see it all the time. It's my hospital did it, but we did it from the standpoint we wanted people to be aware of new services that we offered. But most of the advertising I see is, look at us, we're great, we're the best. Really? Is that going to make your decisions whether you're going to go to a hospital or clinic or someplace? No, that's based on personal experiences and referrals from your friends and neighbors. But yet, we do that. We have one hospital in the state that gave $5 million for the construction of a football stadium. And how's that going to impact healthcare in Kentucky? In addition to being CEO of my small hospital, I was also a regional administrator for about 6 others. And for one in particular, that would have been their profit for 500 years. And that's just tragic. Another thing we have to do is invert the pyramid. We talk constantly about social determinants of health. We know that 60-70% of the healthcare problems are based on social determinants of health. So why don't we address those? Well, we don't have the money. We had the money. Listen to me, we had the money. Particularly in Kentucky, $15 billion Medicaid program. If we invert that pyramid, invest those dollars in the social determinants of health, we improve the health, makes funds available for everybody else, fair payment rates for providers. It's a win-win relationship. But why don't we do it? Couldn't tell you. Reduce bureaucracy. That's low-hanging fruit. We spend over 30 cents of every dollar in the United States on the administration of health care. Again, double what other industrialized nations do. Specific to our Medicaid program, we have 6 managed care organizations to handle 1.7 million people. They automatically get 10% off the top. Our Medicaid department within state government, their expense is about 6 to 7%. So we're at 16% just there, 17% just there. And that doesn't count the administrative expense that you folks as providers have to incur, and it is substantial. I would guess for a Medicaid program, probably we're spending more or closer to 35-40% of every dollar just on administration. Why don't we change that? I've had a bill for the last 4 years that reduced the number of MCOs from 6 to 3. Because you all know if you're working with MCOs, you got 6 different set of rules. It's never consistent. It's ridiculous. State of Tennessee, which obviously to our south, our population is 4.3 million. They're right at 9 million, but they also have 1.7 million of their population on Medicaid. They have 3 managed care organizations. State of California has 26 managed care organizations, but due to per capita, and it comes out about, they take care of 1.6 million per MCO. That's one of the arguments I get about reducing the number. It's too much risk for our MCOs, and they'll jettison the market. No, they're not going to jettison the market. We're going to see some bills this time based on, or trying to address the issue of pre-authorization, which is ridiculous. It's just an opportunity to put another obstacle in front of making payments to providers. You can't tell me with the technology that we have today that we don't have algorithms out there that can look at every provider in Kentucky and say, here's the good ones, here's the bad ones. Focus on the bad ones, leave the good ones alone. So we need to try to address that. We've got to have a tort reform in Kentucky. It's killing us. My small hospital, getting 75 beds, service area, about 100,000 people, county's 26,000. We were the last to do obstetrics, still do. But it costs us $1 million or $500,000 a year to provide insurance coverage for about 3 obstetricians. $500,000 before you see the first patient. We can't afford a service. And that's when, as a responsible hospital CEO, I said on many occasions that maybe we need to stop doing this. We can't afford it. But here's a life-changing event for me. I had a nursing assistant come to me one day and tell me that she walked in on an 18-year-old who had delivered a premature baby, and she found the mother crying. She's trying to console her. Says, she's going to be fine. Your baby's going to be fine. It's one of the best hospitals in the United States. She says, that's not why I'm crying. She says, what's the problem? She said, I don't have the gasoline money to drive to Louisville to see my baby, 70 miles away. So the epiphany for me is if she doesn't have the money to go see a critically ill baby, she doesn't have the money for prenatal care. And if she has a baby, for postpartum care. That's not quality care. But we overlook that for rural Kentucky. You know, we think, let's just regionalize our services. With people understanding, particularly this time when gas prices are over $3 a gallon, that even a 30-mile trip is a financial burden. But again, if we're designating those resources to the local communities, we can address that shortfall. I mentioned profiteering very roughly. It doesn't have its place in healthcare. Again, I think we need to reward innovation, but if you've got a monopoly on a system and that's where you're getting your profits from, that's immoral. And I do believe what Gandhi said, that one of the 8 deadly sins is commerce without morality, and we see it every day. I'll remind you again, an insurance company that had $84.6 billion profit. CEO makes $20 million a year. How does a person spend $20 million a year? That's beyond me. I mean, once you buy a car and you buy a house, what do you do with the rest of it? Just hoard it? I don't think that's a real healthcare professional. I truly don't. Another thing we have to do is commit to pursuing symbiotic relationships. We work too much in silos as healthcare providers, and we don't understand the impact we have on each other. One of the greatest lessons I learned in the Senate my first week there with Senator Steve West, he said every legislation that we pass has unintended consequences, and it does. But it's the same with our relationship with each other. We can't address one issue without having an impact on somebody else. We need to understand that impact. You know, as CEO of a small rural hospital, again, I was there for 30 years. Average tenure of a hospital CEO is about 5 years. So I went through a lot of CEOs in my area from Bowling Green and Owensboro and Louisville. And anytime I knew when you would come to town, they'd call me up and say, let's have lunch. I'm going to be your new BFF. So I'd meet with them and I'd say the same thing I always did. Hey, this is great. If you'll help us keep our primary care and our secondary care, you can have all the tertiary care you want. And secondary care we can't take care of here. And without exception, they would look at me like, and one even had the boldness to say, but we want the primary care too. Then where's the relationship from? I had one system, we had a close affiliation with the Norton Healthcare System, and I had a cardiology clinic that was a very successful cardiology clinic. Had another system call me up one day and said that we want to do a cardiology clinic at your hospital. I said, I appreciate it, but I don't think I've got the critical mass to support two. If I bring another one in, it may cause me to lose the one. They said, you're not listening to us. I said, what do you mean? We're going to do a cardiology clinic in your community. Either you provide us the space or we're going to do it off campus. But really, that's not a symbiotic relationship. And where's the value in that? My small hospital, we built a relationship with the neighboring hospitals because we didn't have the critical mass for some specialties as well. So I would tell them, if you let us do outpatient clinics here, you can have the outpatient surgery, but the inpatient stuff has to come back to us. I said, fine, that's great. Well, it worked well for some time with one particular hospital, but then they decided, no, we want to recruit our own. And our board got a little bit agitated at that, and they said, let's just pull them all out. Let's let them fold. Didn't that make sense? No, it didn't make sense. Because, again, what's special about healthcare in rural Kentucky is it's our economic foundation. It's if we close that hospital, we'll get their patients, but what we're going to get is the self-pay, the no-pay, and the Medicaid. That does not help us. And that's what frustrates me about urban-rural relationships. And again, if you let us keep our primary care and secondary care we're capable of taking care of, you can have the rest of it. They don't understand. If we build up rural Kentucky and reduce the Medicaid population, they're still going to get their patients, but now they're going to be patients with commercial insurance. That's why I'm a big proponent on John Nash's theory of economic equilibrium. And we won't get into the big discussion about that, but John Nash, you may have seen the movie It's a Beautiful Mind. And the base of his theory was he and some friends had gone to a bar one evening, and some girls came in. One in particular was just knockout gorgeous. Well, all the guys wanted to date the one girl. And this is where he literally developed this theory. He said, guys, there's 4 other girls here that are pretty good looking. Either we can all concentrate on this one girl and all of us go home with nobody, or we can look at these other 4 and build a relationship. So it's a win-win. And that's what he says about commerce. The traditional capitalist model is, I build my business by taking your business. That's not the way you do it. You build a bigger pie. You still only have 50% of the pie, but it's a bigger population for you. And that's what we have to do in Kentucky. I guarantee if we'll make the investment in primary care for rural Kentucky, we will see dividends like we've never seen before. And that helps fund all these other things that we have these shortfalls. We truly do. I think another thing we have to do is build a culture of self-reliance and reasonable expectations. We have too many people on welfare, and I'm not condemning them at all. I'm not being judgmental about them, but it's become a generational problem. My wife was a second grade teacher for 30 years, and her last year, she did a career day for second graders, which I thought was kind of neat. So she's asking, what do you want to do when you grow up? I go, what do you mean? What kind of job do you want? And I kid you not, classroom of about 30 kids, the majority of them said, we want to get a check. That's tragic. We've got to address the poverty in Kentucky. And it concerns me that we kind of just throw stuff against the wall and hope it sticks. In eastern Kentucky, where it's always been most pronounced, we've spent over $26 trillion on trying to eliminate poverty in eastern Kentucky, and we've not been successful. And it goes back to this mindset about what we expect government to do. Now, I'll show my age when I talk about John F. Kennedy, and he said, and it sounds so foreign today, ask not what your country can do for you, but what you can do for your country. Nobody thinks in those terms anymore. My father only had an 8th grade education. He joined the Army at 17. I lied about his age. Joined in 1938. And he said that the first night he had mess at Fort Knox. First time in his life he can remember his stomach being full. He was in the Army for the duration. When he came home, I never met anybody who had a greater value for education than he. I never remember a time growing up that my 2 sisters and I wouldn't be going to college. It wasn't you're going to do it or else. It's here's what you've got to do. And the lessons he taught me were work hard, get a good education, and don't be a burden on society. When's the last time you heard somebody say, I don't want to be a burden on society? The poor will always be with us. But it should be 10% of our population, not 25%. But we built this culture in this state and this nation that people can't succeed, and they can. Everybody can't be a victim. I think the worst thing that we did as a society was to decide that we were going to give a trophy to every kid at T-ball. That's not life. We're not giving realistic expectations. We need to be teaching our children that your job, and everybody needs a job, your job is not to go to school, your job is to get an education. We don't do that. And that's one of the greatest gifts that we can give them, a free education. You need to take full advantage of it. But we don't do that. Now everybody's a victim of society, and that's got to change. We need to be conscious of the self-talk that we have as a society. Even in healthcare and education, I mentioned too. Why would you want to go into healthcare when everybody's saying, this is a terrible job, I hate it, I don't want to do it? We got to say there are rewards. It is positive. It is good. But we don't think in those terms anymore, and we should. One of my greatest friends in the Senate is Senator Donald Douglas. And you may know him. He's an anesthesiologist, African American. Donald's probably about 63, 64 years old. One of 16 children, Daviess County, Kentucky, Owensboro. One of 16 children. He was 14th, born in a log cabin with a dirt floor. No reason in the world that he should be the success he is in life. But he went to Western Kentucky University on an athletic scholarship. He's actually in their Sports Hall of Fame. Was 2 times in the Olympic trials. Became an anesthesiologist. And he tell you because he had a dream. He knew he could succeed. And that's what's missing so much from our society today. I grew up during a time where we believed you can be anything you want to be in America. And now we don't say that message. It's that you can't succeed because you're being held back. But you look at a Donald Douglas, and he'll tell you, you can be whatever you want to be. When you set reasonable expectations, I wanted to be a professional basketball player. But when I lost my starting position as point guard on the freshman basketball team, I realized I wasn't going to be a professional basketball player. Was that traumatic for me? Boy, it certainly was. I was depressed for ages on end. But you learn from those experiences. We shield our young people from too much. The message we need to give them is life is tough. Always has been, always will be. One of my favorite quotes is from Henry David Thoreau, and he says, the mass of men and women lead lives of quiet desperation. You that roll that forward 200 years, and it's still true today. The mass of men and women lead lives of quiet desperation. In spite of all the advances we made, you would think that nobody would ever be affected by that, but we are. It's our self-talk that we have. I think another thing we have to do is quit ignoring the spiritual aspect of healthcare. We want to take care of the mind, we want to take care of the body, but we don't take care of the spiritual aspect of it. And it is significant. Remember, we had testimony 3 or 4 years ago in the Health Services Committee on teenage suicide and what a tragic situation that is. 3 physicians from UK spoke on this. And I asked a question that wasn't a leading question, wasn't intended to be a leading question, but I asked, all this data you have available, you can stratify it, you can change it. Is there any particular group that has a higher probability of teenage suicide than others? I think, by racial, by income inequality, is there any difference? His first answer was no. It's pretty much consistent across the board. But then he stopped and he thought for the longest time. He said, except there was one small percentage of teenagers that have a lower probability of suicide than others. So who might that be? He said it's kids that, and he searched for the word for the longest time because I guess it wasn't politically correct. He said, kids who have some degree of religiosity. I'm going, if that's statistically relevant, why don't we talk about that? And we should. A lot of issues on mental health right now, and certainly they are real, but more than we've ever seen before, I think, in my lifetime, tragic as it is. And I think part of the reason is that we don't address our spiritual weaknesses. My favorite scriptures is Philippians 4, 6 through 8. Be anxious for nothing, but in everything through prayer, supplication, thanksgiving, let your requests be known to God. And the peace of God, which surpasses all understanding, will protect your heart and your mind through Jesus Christ. That addresses a lot of the mental health issues that we think exist out there today, but we don't offer people that, and that's very unfortunate. The last thing I'd have with you, if we're sincere about changing the healthcare delivery system, how do we go about it? Well, unfortunately, you got to do it through the government. And we have to do a much better job of lobbying than what we do. We do a terrible job. I hate when we go in session because a bill will come up and suddenly I'll get 15,000 emails that say the very same thing, cut and paste, vote against this bill. Really, people? Do I have time for this? So how do you effectively lobby? Well, I'd ask you, show of hands, how many know your state representative? How many know your state senator? How many really know your state representative and state senator? Do you know their wife, their spouse? Do you know where they're at the school? Do you know how many kids they have? Do you know what their favorite sport is? Do you know what their favorite dessert is? Mine's banana pudding, by the way. Now, that may sound ridiculous, but you have to build that kind of relationship with your legislator, and there's no reason why you shouldn't. I appreciate these days when you come to Frankfurt when we're in session for whatever day it is, but we're scheduling people 15 minutes apart, literally. And if you think I can give you the attention that they deserve, I'm going to apologize to you. I can't because I'm thinking about the next group that's coming in 15 minutes later. My first week in Frankfurt, we were scheduling meetings 15 minutes apart. I finally had to ask my legislative assistant, when do I get to eat lunch? And she looked at me kind of incredulously and said, well, you have to schedule it. Literally. If you're waiting to convey your message when we're in session, you're already behind the 8 ball. Bear in mind, again, we're getting into the 60-day sessions coming up where we have to do the budget. We will probably have over 1,200 bills that will be filed during that 60-day session. During this 30-day session we just finished, we had close to 1,200 bills. 30-day session. There's such a small bandwidth here to get legislation passed. It's tough. I'm telling you, even the best bill, non-controversial, non-partisan, it can take 3 to 5 years to get passed because you got to push it through. But who gets the attention? The folks who have built these relationships with their legislator and they know it firsthand. That's the level of intensity that you have to have in a relationship. You're not going to offend a legislator if you had that degree of intimacy, if you want to call it that, with them. Because I tell you, we're human too. We're just like everybody else. When somebody says, hey, I see one of your kids did such and such, we like that. Who wouldn't? And I can tell you, I pay a whole lot more attention to those than people who send me an email saying, you idiot, why did you vote for this? But that's what I encourage you, is build that relationship. Don't just know them, build that relationship. Last thing I'd leave with you is one of my favorite riddles. And some of you in government committee meetings have heard it 3,000 times. I'm sorry, you're going to hear it 3,001, but you got 5 frogs sitting on a log. 3 decide to jump in. How many are left? 5. Because deciding to do something is not the same as actually doing it. And that's what's missing so often. Folks will say, well, you need to do such and such. Well, why don't you do such and such? We're great at saying we need to do something, but we don't actually take the steps. So what I would encourage you to do is, as Gandhi suggested, and be the change that you want the world to be. It starts with each and every one of us. I had a doctor that was from my home community and really came up in a very tough environment. Pretty much his family never amounted to anything. And I asked him one day, I said, I don't mean to offend you, but how'd you become the man you are? I mean, this guy was just a class act. Yeah, you'd never guess that he came from Grayson County, Kentucky. You think he's cosmopolitan to the hilt. I said, how did you become who you are? And he said without hesitation, he said, 5th grade, Orrin P. Lawler came to my classroom. Orrin P. Lawler was the superintendent of Grayson County Schools. Orrin himself was like 6'5", ramrod straight, wore a shirt and tie every day of his life. When you saw him, you knew who he was. And this doctor said, from that point forward, I wanted to be Orrin P. Lawler. What is leadership? Leadership is changing people's behavior, influencing people's behavior. I'm telling you, each and every one of you is a leader, whether you want to acknowledge it or not. If you're saying, no, I'm not a leader, you don't understand the impact that you have on people. I love the line from the movie, It's a Wonderful Life, where Clarence says, it's amazing how one person's life touches so many others. And every day you influence somebody and you're not even aware of it. So I ask you, be aware of that, be conscious of that, and be the change you want for this world to be. And I guarantee if we all do that, it'll be a much better place. I thank you all for the opportunity to speak to you today, and God bless you all. Thank you.
Senator Meredith, thank you very much for being here. And before we have some lunch directions, I just want to share a few of the key messages that I heard from Senator Meredith. And it's a privilege to get to work with him as the chair of the Health Services Committee. I heard, he challenged us to get involved in your community and not to forget your legislator. Find your legislator in your community, get involved, and then become united around the single mission to improve the health outcomes in your community. And what resonated there is we can improve the health outcomes in Kentucky one community at a time, at the same time, right? We don't want to wait for one community. We all want to improve together. I also heard overcoming our fears and embracing change. And I think that really comes in and ties into what we heard all this morning, what it means to create those symbiotic relationships where it's not a matter of giving up something for someone to be better, but it's like, how do we work together to build those symbiotic relationships that can realize our mission and vision to improve the health outcomes of Kentucky. And I'm going to restate his mission in investing in primary care and family physicians. You're going to hear this afternoon, we're heading toward a cliff of family physicians and rural communities having access to primary care, and that's where we really need to focus and invest in that prevention. Thank you, Dr. Moyer, for your presentation. And I'm going to restate the quote. The best way to predict the future is to create it, and we're all can be those leaders and create the change we want to see. And finally, before I move on to my red remarks, is I just want to sum up the entire morning. Many of you may have come here today, me included, in thinking that I knew where the problems are, or I know what the problems are in our healthcare system in the state of Kentucky. And maybe I do, and maybe I don't. Maybe you all do, and maybe you don't. But I think what we can determine from this morning is that if we can create the symbiotic partnerships, the trusting partnerships, create a coordinated data sharing platform in which we can all be comfortable with sharing the data, we might know the problem, but having these relationships and data sharing can define the problem, and defining the problem points us to the solutions in which it creates the healthy Kentucky that we're all looking for. So summing it up, Senator Meredith, thank you. I think it tied very nicely into all of our morning presentations.